grateful for the opportunity to speak to you today. I've spoken at this meeting before, and in fact, I bought my plane tickets, made all my arrangements to be there when, as you pointed out, the FDA decided that I had to be in Washington, D.C. on Friday the 13th. I hope that date doesn't predict the outcome of the meeting. Can you see my slides on the screen now?
No, not as yet.
Okay, well,
do we need to switch screen sharing?
well, while you're getting that organized, for those of you who haven't met me before, as you pointed out, I was born in Brisbane, educated there, University of Queensland, where I went to medical school. I went to the United States for a year in 1988, and I never got that return ticket. So I've been there ever since at Mayo Clinic, Columbia University, and the National Institutes of Health. And it was at the National Institutes of Health where I first got involved with NPC. And it's really been a great focus of mine since then. And, you know, just to reinforce what you've said, there's a lot of science I'm going to talk about, but this is really all about children and families and relationships. And I have to say, this is a terrible disease, but I also have to say that the relationships I've developed, what I've learned from families has really been a highlight of my personal and professional life. So I'm very grateful to this community for what they've taught me. I've done my best to try to give back, but this has been a shared effort all along as we try to make progress together.
So we have you on screen now with your slides.
Terrific. Okay, well, let's move along then. Here are all my typical disclosures. As you may have heard, I retired after 43 years of practice at the end of last year. My wife could stand me at home for about 5 minutes, so I then took another job. But this time, rather than practicing general child neurology as well as research and doing editorial work, I'm entirely focused on developing therapy for NPC and similar disorders. What I thought I'd do is give an overview of the history of NPC. Now, I can't cover all of this, but I wanted to give you a 30,000-foot view just to get a sense of the progress that's been made, where we've come from, and how much has been accomplished. We have to go right back to 1914 when a pediatrician in Berlin described a little girl who had a progressive disorder that came on in infancy, was associated with an enlarged liver and spleen, involvement of the lungs, and she succumbed to this disease very early. He recognized that this looked different from the disease that Philippe Gaucher had described in 1882, which was Gaucher's disease. So he called it in his paper, ein unbekanntes Krankheitsbild, which means an unknown disease. He didn't know what it was, but he knew it was different. In the 1920s, a great German neuropathologist called Ludwig Pick studied tissues from this child and other similar patients and found that they were storing lipid in the tissues in characteristic structures called foam cells, and he was able to define the disease pathologically. Later in Germany in the 1930s, Ernst Klenk, a biochemist, showed that a compound called sphingomyelin was accumulating. So that was the state of the disease. And what they were describing is what we would now call acid sphingomyelinase deficient NPD, or what used to be called Niemann-Pick A and subsequently Niemann-Pick B. Matters got confused in the 1950s when Alan Crocker and Sidney Farber, who were pediatricians at the Boston Children's Hospital, decided they wanted to look at the Boston Children's Hospital experience of Niemann-Pick disease, and they defined the disease based on the presence of lipid storage in the tissues with characteristic foam cells. And in so doing, in the 18 patients they described, who they'd seen over a 30-year period, they expanded the range of the disease. So it wasn't just young children, infants who were affected, but now there were teenagers, even some young adults who were affected. So they thought this was all the same disease. And 3 years later, Alan Crocker divided Niemann-Pick disease into what he called groups A through D. Now, A and B, again, are what we now know to be acid sphingomyelinase deficiency. And Roscoe Brady, for whom I worked, showed in 1966 that this was the deficiency in those patients. Type C and D were clinically indistinguishable, but he described type or group D as a separate group based on the fact that these were patients who had a common ancestor from Nova Scotia. It was actually a man called Jean Amiraux who migrated there in 1673. We now know that they have mutations in the NPC1 gene, so it is actually the same disease. I mentioned that Roscoe Brady discovered acid sphingomyelinase deficiency in Niemann-Pick A and B. And what he found in the Niemann-Pick C patients he looked at was they had very variable levels of abnormal acid sphingomyelinase deficiency. It was hard to make sense of that. Well, in the 1970s, Peter Penchev, with whom I also worked at NIH, was sent a mouse from a toxicology center in Arkansas by a veterinarian called Alice Booth. And Dr. Booth had looked at this mouse, in fact, these mice, and thought they seemed to have some sort of lipid storage disease. So he sent it to the leading lab in the country, which was Roscoe Brady's lab. And Peter Penchev began to investigate it. And as you can see from the slide, there were a series of investigations he began in the late 70s and continued through for more than 20 years, where he discovered that these mice actually, initially, they had low levels of both glucose cerebrosidase, the enzyme that's deficient in Gaucher disease, and acid sphingomyelinase, deficient in ASMD. But he later learned that, in fact, there is not a primary problem with these enzymes. The reason their activity is diminished is because of the storage of cholesterol in the cells, which impairs the function of these enzymes. And at this point, he was able to develop a test to demonstrate that abnormal movement of molecules within the cell with what's known as the endosomal lysosomal system led to accumulation of cholesterol and other compounds, including what are called glycosphingolipids, which are combinations of fats and sugars. And his lab, of course, continued to work on this. They're involved in the cloning of the NPC1 gene, and he did further studies later on. This next slide is one of Peter's originals from around 1980, which he was kind enough to give me. And what it shows is that if you look at the response of normal cells, which are cultured in a medium with no lipoprotein or deficient lipoprotein, then expose it to a burst of LDL cholesterol. In a normal cell, shown here, the LDL receptors on the surface of the cell rapidly downregulate. The cell gets as much cholesterol as it needs quickly, so it downregulates the receptors. The NPC cells have a delayed and diminished response. Similarly, the synthesis of cholesterol in cells, of course, is suppressed when they take in cholesterol from outside. Again, that response is delayed and diminished. And when cholesterol esters are taken into the lysosomes, they're broken down by an enzyme called lysosomal acid lipase. They then are trafficked, they're transported into the endoplasmic reticulum of the cell, where it is reesterified because the cell doesn't like free cholesterol. And again, as you can see, that reesterification is very rapid in control cells, very much diminished in mutants. So all of these normal responses to a load of cholesterol are delayed and diminished in the NPC cells. And you see the result in this next slide. These are fibroblasts, cells you obtain from a skin biopsy, which have been stained with a compound called philipin. Now, it's called that because it was found in a microorganism called Streptomyces philippinensis, which was discovered in the Philippines. That's where the name comes from. And this compound forms very strong bonds with unesterified cholesterol. And if you shine an appropriate wavelength of light on it, it fluoresces. And what you see here is this dramatic fluorescence indicating unesterified or free cholesterol within lysosomes in the cell. They're not in the Golgi, they're not in the nucleus, but they're scattered throughout the cell. And for many years, this was the diagnostic test for Niemann-Pick disease type C. So you needed to have a skin biopsy, culture the cells in lipoprotein deficient serum, expose them to a burst of cholesterol, measure the esterification rate, stain them with philipin. This typically took 6 to 8 weeks, very difficult to do. And it turns out that as many as 20% of patients who really had Niemann-Pick C had a pattern which looked a bit like a carrier. So a very imperfect, expensive, and difficult test. But that remained the gold standard right through into the 2010s, as we'll see. Okay. In 1990, there was an important development when it was recognized that there is a cat that has NPC, and that colony, which was originally in Colorado, was subsequently transferred to the University of Pennsylvania in Philadelphia. More recently has moved down to Florida with Charles Veet. In 1993, when I was at NIH, we did a study where we thought, well, there's a lot of cholesterol in the cells. What would happen if we tried the best cholesterol-lowering drugs we had available 30 years ago? And what we found was we could lower the cholesterol concentration overall in the liver. We did liver biopsies before and after. But we really didn't seem to affect the course of the disease. We didn't understand then that it's not just the amount of cholesterol, it's being in the wrong place in the cell. Now, very interestingly, again, Peter Penchev, Joan Blanchette Mackey at NIH in 1996, Ed Neufeld was the first author of the paper, studied 2-hydroxypropyl beta cyclodextrin, which I'm sure you're all very much familiar with, and found that it depleted cholesterol in the plasma membrane. I thought this was a really good tool to do biochemical studies, but it never occurred to them at that time that it could be therapeutic. Now, interestingly, around 2000, the group in Arizona actually tried this molecule or a form of this molecule in mice and saw no benefit and pursued it no further. As you'll see, however, it turns out that it did have an effect and is currently being studied. In 1996, as you heard, the NPC1 gene was cloned. 2000, the NPC2 gene was cloned. In 2001, Steve Walkley's group, that's the Zervis paper, found that a compound called N-butyl-deoxynogeremycin, which you know as miglustat, was effective in delaying the onset and prolonging the life of the NPC mice. This led to the subsequent trials of miglustat. And as you can see, in 2007, we published the pivotal trial of miglustat in human NPC, which subsequently led to approval of this as a therapy for NPC in the European Union, Canada, Australia, many other countries, but not the USA. The FDA did not like our endpoint and declined to approve the drug, although an advisory committee had recommended that should be done. In the meantime, in 2004, Cindy Mellon, who is an obstetrician who was interested in compounds called neurosteroids, started to study the NPC mice and found that a neurosteroid called allopregnanolone was very low in these mice. And so this is the Griffith et al. Paper. So she gave a single injection of allopregnanolone to the mice and doubled their lifespan. If she gave multiple injections, they lived much longer. There was huge excitement about this, and plans got underway to try to study this. Now, at first, it was thought allopregnanolone is not really suitable in its form to give. So initially, it was thought perhaps we should study ganaxolone, which is an oral analog of allopregnanolone. Preparations were underway. This is when Denny Porter and his team at NIH got involved with this disease. But in the meantime, independently, Kristen Davidson, working with Steve Walkley's group at Einstein University in New York, and Benny Liu, working with John Dietschy's group at UT Southwestern in Texas, independently discovered when they tried to reproduce these studies that it was not the allopregnanolone producing the effect, but the vehicle, the compound in which it was suspended, hydroxypropyl beta-cyclodextrin, that was producing the effect. And that led to a large series of studies. I'm not going to go into them. You'll hear something about one form of this later in the meeting. Suffice it to say that there was a randomized, double-blind, sham-controlled trial run, predominantly in the US, which failed. Now, I think most of us in the field don't believe it failed because cyclodextrin doesn't work. It failed because of the way the study was designed. And I don't have time to explain all that now, but a great deal of data has been gathered. And I think there's a general consensus that cyclodextrin intrathecally does have an effect. There's a current trial underway of intravenous cyclodextrin. You'll be hearing more about that. The next big development, I think, was, again, something building on work which had been done by Peter Penchev. In the 90s, he'd found that oxysterol levels were elevated, but again, he thought this was interesting in terms of understanding the biochemistry. But Dan Ory's group at Washington University in St. Louis actually found that oxysterols could be useful for diagnosis. Now, I don't want people to run from the room screaming when they see this diagram. All I want to show you is here's cholesterol. And one of the ways that the body deals with cholesterol is to oxidize it. It means you add an oxygen molecule. And one of the ways you do it is through this pathway leading to this compound, which is called cholestane 3-beta 5-alpha 6-beta triol. And you see these OH groups. That's where it's been oxidized. The body deals with free cholesterol by oxidizing it to these other oxysterol compounds. And it turns out, if you look at this compound, here you see control subjects, the number of subjects, and the level of their cholestane trial on the left. In black, you see the patients with NPC. Underneath this is what's called a receiver operating characteristic curve. I'm not going to go into the details of that, but basically, the more closely this adheres to the axes, the more perfect this is. This is about as good as you get without fudging the results. So this is a very, very good test to demonstrate the presence of oxysterols which correlate with free cholesterol. And essentially, this test has replaced the skin biopsy in Philip and Stoney. It's been a very important development. It's not a great test for newborns because they frequently have jaundice with this condition that can swamp these results. But the next stage in oxidation are compounds called bile acids. And there's a very specific bile acid, which is also very helpful for diagnosis and has great potential to be used for newborn screening. Okay, moving right along in the same year, there were studies performed looking at what's called HDAC inhibition, which is a way of generally increasing expression of genes. That was promising, but a subsequent clinical trial of a drug that's been approved for another indication did not give any positive indications, and that has not been pursued further. In 2014, a Japanese group actually gave two patients, hydroxypropyl beta-cyclodextrin, which we usually think of as cyclodextrin, into their cerebral ventricles with positive results. Subsequent to that, the group in the US at NIH and Liz Berry-Kravis in cooperation, who you'll hear from later in this conference, started open label trials. They published that in 2017, showing beneficial results. As I mentioned, the actual randomized double-blind controlled trial failed, and that's never been published. But there's more and more long-term data, and I'm sure you'll hear about that, indicating a positive effect of cyclodextrin. Now, the intracerebroventricular cyclodextrin has also been used in the cats, even in tiny newborn mice with positive results. Now, of course, in fairness, it's not likely we would be able to do that in humans, but as proof of principle, that's been very useful. In the meantime, in 2015, Tatiana Bremova et al. And Michael Strupp, who were both at the time in Munich, found that if they gave a compound called N-acetyl-L-leucine to patients with NPC and a variety of other ataxic disorders, they improved, quite unexpectedly. And that led to subsequent scientific studies which showed that it was actually what's called the L enantiomer of acetyl-leucine that was effective. I'm going to explain those terms a little later. In 2020, we were able to put together long-term outcome data for miglustat showing what I think are quite convincing evidence of a benefit. Miglustat is not the whole answer. It never was thought to be, but we do believe it has an effect in contributing to the slowing of disease. In 2021, Euchen Mengel, myself, and others published the results of a randomized double-blind placebo-controlled trial of arimoclomol in NPC, which was positive. Although the FDA didn't like the outcome measure, they gave a negative result. It bankrupted the company, but fortunately, another company took this over and has subsequently taken that through to approval, as you'll learn. The randomized double-blind controlled trial of N-acetyl-Leucine was published last year in the New England Journal of Medicine. And last year in September, within 4 days, both arimoclomol and N-acetyl-L-leucine were approved by the FDA for the treatment of NPC. Arimoclomol was only approved together with miglustat because the FDA and the advisory committee expressed some concern that it was difficult to separate the effects of arimoclomol from miglustat. N-acetyl-L-leucine was approved as a freestanding treatment. Okay, so that was a very rapid overview of a lot of history. I hope it wasn't confusing, but I wanted to give you a sense of a great deal of the progress that's been made, particularly in the last 35 years since I've been involved in this field. If we think about the approaches that have been used to therapy, initially, as I said, we thought, well, there's too much cholesterol in the tissue. What if we use standard cholesterol-lowering drugs? They don't work. But if you use agents such as the cyclodextrin, which seem, and we don't know how these work, but which seem to help move the cholesterol out of the lysosomes to the ER and sites where they work, then that certainly there's a great deal of evidence suggesting that that can be effective. And you'll learn more about that during this meeting. The initial approach that was used with miglustat was to try to lower the amount of glycosphingolipids in the tissue because they also accumulate with cholesterol. They also have toxic effects. That led to the approval of miglustat. Nizobaglustat, which you'll also hear about in this meeting, is a more potent and more specific inhibitor of glycosphingolipid synthesis. It's actually a dual inhibitor, and a trial is about to get underway for that in NPC. We mentioned HDAC inhibition, which was not effective. Antioxidants, we tried vitamin E in the mice way back in the early 90s. It didn't work. N-acetylcysteine, which is used to treat Panadol overdose, was not found to be effective at the NIH. But the next approach, which stemmed from work in Denmark, was to try to increase the expression of what's called heat shock protein. When cells are stressed, and one way you can stress them is to overheat them, they have a number of cellular responses, and one is to release protective proteins, which are called heat shock proteins. And this was the basis of therapy with arimoclomol, which, as you've heard, has been approved with miglustat. N-acetyl-L-leucine we're going to talk more about, but it seems to both enhance mitochondrial energy production and lysosomal function, as we'll see. Let's talk about miglustat. Again, I think many of you are probably familiar with this. It has become the standard of care, I think, around the world. It's basically a glucose molecule with this side chain added in. Here's a normal glucose molecule. Here's miglustat. It fools this enzyme called glucosylceramide synthase to think it's glucose, and thereby inhibits the combination of ceramide and glucose to make this compound called glucosylceramide, which is the first building block for all of the glycosphingolipids, which include things called the gangliosides, cytosine, and many others. So that was the rationale for that therapy. The trial, which we reported in 2007, was a phase 2 randomized controlled trial, miglustat versus standard of care. It was not placebo-controlled because we expected it would be immediately unmasked, simply because most people who take miglustat get GI side effects. And those of you whose children or adult children are taking this will be very familiar with that. As our primary outcome measure, we measured horizontal saccadic eye movement velocity. Because saccadic eye movements are typically affected in NPC, it's very characteristic. Most people have very severely impaired vertical saccades by the time they are diagnosed. So we measured horizontal saccades. In fact, the group in Melbourne were our blinded reviewers of that, and they've, of course, been leaders in this field for many, many years. We found that the velocity of these movements improved in the patients treated with miglustat versus those receiving standard of care when we excluded patients who were taking Valium-like drugs, which affect these movements. Then it was a statistically significant result. And as I said, this was the pivotal trial that led to approval of this treatment around the world, except for the US. This was just some of the original studies in the mice showing delay in onset, increased lifespan, as well as pathological benefit. I'm not going to go into all this in detail just because of limited time. But again, if you look at these slides, basically here you see the brown stain indicates GM2 ganglioside, one of the glycosphingolipids that accumulates. Here you see the cortex on this side, the cerebellum on the right. Here is untreated with lots of brown, less brown with treated, untreated in the cerebellum with lots of brown staining, much less with treatment, and so on in mice and the cats below. So there was evidence that this drug was actually doing what it was supposed to do. This led, as I mentioned, to EMA approval on June 16th, 2009. It was indicated for the treatment of progressive neurological manifestations in adult patients and pediatric patients with Niemann-Pick Type C disease. Okay, we looked at long-term outcome, and Olivier Morant, who was with Actelion at the time, was a great help in organizing this. We managed to get together 789 patients from 5 large national cohorts, plus the NPC registry that had been established in Europe after miglustat was approved. We looked at a group where we could define the neurological onset versus diagnosis, 669 in the first group, 590 in the second group, and we found in both groups there was increased survival. And interestingly, at that time, the mean delay in diagnosis was about 5 years. And if you look at the data, this is the neurologic onset group you can see here. The mean increase in survival here is of the order, it's actually somewhat over 5 years. It's about 5 years here if you take time from diagnosis. But these results are really consistent because the difference is accounted for by the delay in diagnosis. But again, the treatment group, this is not a cure, no one pretends that, but certainly there is a slowing of progression and an increase in survival with this therapy. Similarly, Denny Porter and his group at NIH were able to look at a number of patients prospectively over a mean of about 3 years, and found that swallowing was improved in the miglustat group compared to controls. And we know that swallowing ability is one of the major correlates with survival. In fact, Mark Walterfang co-authored a paper with me on that very important subject. Okay, so miglustat, it has an established place. It is by no means the whole answer, but there is evidence that it helps. Arimoclomol, this is the chemical compound structure for those of you who are interested. And it was found in work by Thomas Kierkegaard and his colleagues in Copenhagen that in studies with recombinant human heat shock protein 70, which I mentioned earlier, you can improve survival in mice and show benefits in tissue culture from a number of lysosomal diseases, including NPC. Now, interestingly, we had known from the early 2000s from the work of Richard Hawkes in Calgary that if you look at the cerebellum of mice and stain it with a compound called zebrin, which is actually aldolase C, the zebrin positive stripes correlate with relative sparing of the Purkinje cells, which bear the brunt of this disease. And so the question was, well, what's going on there? And amongst the other compounds that were there was a particular heat shock protein. So this really raised an interesting possibility about therapy, which the group in Denmark followed up. And this just shows you again some of these pictures showing relative sparing in the zebrin positive stripes. Now, again, this is by no means sufficient to save the mice, but it does give an indication of at least a factor which might be helping survival. So why not use recombinant human heat shock protein? Well, you can't get that into patients easily. And so what was done was to use this compound called arimoclomol, which enhances the expression of heat shock protein. So it's an indirect way of expressing this compound. So this was a phase 2/3 prospective, randomized, double-blind, placebo-controlled, quadruple-masked, 1-year study in which the 5-domain composite NPC severity scale was used as the outcome measure. 51 patients from 2 to 18 years were studied, and essentially it showed slowing of progression. The group who were on miglustat plus this actually was stable for the first year. They subsequently improved. The group who were not on miglustat, which was a minority of patients because it was standard of care, probably did a little worse than placebo, but in fairness, that's likely because there are a couple of patients randomly in that group who had very severe mutations, which predicted early onset and rapid progression. The long-term data for arimoclomol is shown here. So they projected the placebo control from the first year and looked at progression of arimoclomol plus miglustat, plus or minus miglustat, which was lower. There was still progression, but not at the same rate expected. If you looked with miglustat, it was better still, as was miglustat by itself. So this was sufficient information for the FDA, as I said, to approve arimoclomol in combination with miglustat for the treatment of neurologic manifestations of NPC in adult and pediatric patients 2 years of age and older, and that was on September 20, 2024, followed later by the approval of this drug. Now, I'm just going to explain a little bit of terminology. Every drug has at least 3 names. One is a chemical name. So for this drug, the chemical name describes the structure. It's N-acetyl-L-leucine. What's called the United States adopted name or international non-proprietary name, which most people call the generic name, is levacetyl-leucine, and the trade name is Acnosa. Just to try to head off any confusion there, because it is confusing, this multiplicity. Now, this is leucine, which is a normal essential amino acid. This is an acetyl group linked through an amide bond, through a nitrogen. So that's the N-acetyl-L-leucine. Well, what about the L part? Well, if you have organic compounds, that is to say carbon-based compounds, carbon is able to form 4 bonds. If there are asymmetric groups around it, then you can have so-called left-handed and right-handed forms. And if you hold your left and right hands up and try to superimpose them, you can't. And that's, in a very simple way, describes what are called the left and right-handed forms of these molecules, which are also called enantiomers. A mixture of right and left-handed forms is called a racemic mixture. So N-acetyl-D, the right-handed form, N-acetyl-L combine to form N-acetyl-D-L-leucine. Now, it turns out this molecule was approved in France to treat vertigo way back in 1957. It's even older than me, not by very much, but slightly older than me. And it's been used very safely for that period of time. It turns out that Michael Stripp, the neurologist I mentioned in Munich, some years ago was treating a patient who had vertigo and ataxia, and he went to France, bought this compound and gave it to his patient. His vertigo didn't get much better, but the ataxia did. And so Michael then embarked on a series of open label studies of this racemic form of the drug in disorders which featured ataxia, which included Niemann-Pick disease type C. So that's how this molecule came to be studied. And that he published a case series in ataxias in 2015. Tatiana Bremova with him published it specifically in NPC the same year. A randomized clinical crossover trial of the racemic mixture was published in 2021, looking at a wide range of ataxias. They did not see a positive result there, but again, there were many different diseases. It was really underpowered to show benefit. But in the meantime, the group at Oxford University in the UK had got interested in this molecule, particularly Fran Platt's group. First of all, they tried to understand, well, why would this acetylated amino acid be working? It turns out that L-leucine, the normal amino acid, is transported into cells by what's called the large neutral amino acid transporter, called LAT. This is very limited in its capacity. It's also quite specific. When you add the acetyl group to the L-leucine is electrically neutral. When you add the acetyl group, it becomes negatively charged. And under these circumstances, it can use several of a family of transporters called monocarboxylate transporters, or MCTs, which have a very high capacity and bring a lot of this molecule into the cell. So you can transport the N-acetyl-L-leucine across the intestinal membrane into the bloodstream and then into the brain, the glia, and in fact, tissue throughout the body. An interesting sidelight, this transporter exchanges N-acetyl-leucine for lactic acid. So if you have a cell in which the mitochondria are not functioning normally, it will tend to be preferentially transported into the sick cells. Now, once the N-acetyl-leucine gets into the cell, an enzyme called an acylase breaks off the acetyl group to release the L-leucine. The effects of these two molecules, as we'll show you, are to increase gene expression in the nucleus, decrease inflammation, enhance mitochondrial metabolism, enhance lysosomal function. A number of studies were done in animals and cells. I'm not going to go through this in great detail, but just to focus on this, the key subgroup of an enzyme called pyruvate dehydrogenase, which feeds molecules into the Krebs cycle, which is really at the heart of energy metabolism in the cell, shows that in NPC cells here in orange, you see the NPC mice, the level of this subgroup, this subunit of PDH is decreased. It's returned to normal levels after exposure to NALL, which correlates with enhanced energy production in the cell, which is otherwise deficient. If you look at inflammation, this is a control mouse. Here's an NPC mouse. You can see the loss of Purkinje cells in red, the increased green, which shows inflammation. This is decreased with both the racemate and the N-acetyl-L-leucine. With the D-leucine, there's no effect. And this can actually be quantitated. I'm not going to go through this in detail, but simply to point out, if you go very carefully, you can see that the N-acetyl-Leucine is helping preserve the cells and reduce inflammation, and you can measure this quite accurately. Interestingly, if you look in a model of a form of GM2 gangliosidosis called Sandoff disease, where there's excessive flux through the Krebs cycle, here you see the increased level of this enzyme called glutamate dehydrogenase compared to controls. This drug reduces the level back to normal levels. So it seems that what it's doing is modulating homeostasis in the cell. We'll see more of that. This shows the symptoms in the mice. So here is a control mouse. Here's an untreated mouse. Higher values are worse in terms of the mouse, the gait in the mice. If you start treating the mice at 8 weeks, they get a bit better. Treat them at 3 weeks, they're almost as good as control mice. Now, some very recent work, which has just been published in preprint form a few weeks ago, again by Emily Eden and Fran Platt at Oxford and in London, looked at human fibroblasts from controls and patients with NPC. And what they found is here are the control cells. So you can see Philippin, there's hardly any staining, the size of the lysosomes measured by lysotracker, the co-staining of Philippin and lysotracker. Here are NPC cells, chock full of Philippin, big lysosomes, correlation. After incubating them for 3 days with NALL, there's a marked reduction in the Philippin, decrease in the size of the lysosomes, much less co-localization, and you can actually measure this. Here are the control cells with vehicle, with NALL, no difference. Here are the NPC cells with vehicle, with reduced Philippin, with NALL. Similarly, if you look at the size of the lysosomes, no change in the controls, but with NPC1, reduction in the size of the lysosomes with NALL. If we look at the amount of total cholesterol, here's a control cell, NPC cell, reduced with NALL. We look specifically at the free cholesterol, same thing, control, increased in NPC cells, decreased with treatment. And if we look at esterification, normal values, decreased in the NPC cells, and increased, again, back to normal values with NALL. Interestingly, you can actually measure the connections between cells. Here are control cells where you can see the connections between the mitochondria, shown in green, and the lysosomes, shown in magenta. And there are very few of them in the control cells. In the NPC cells, shown by the arrows, there are too many connections. So in NPC, instead of the communication being from the lysosome to the endoplasmic reticulum to the mitochondria, the normal pathway for metabolism, there's a bypass. So too much sterol cholesterol gets into the mitochondria and disrupts its function. And you can actually measure these contacts. Here they are in controls, markedly increased in NPC, reduced to normal values with NALL. Similarly, if we look at the amount of cholesterol, there's a correlation. So when you reduce the cholesterol, you reduce the contacts. And of course, this drug does both. I'm not going to go into too much detail there. Same thing, there's a reduction in the contacts between the endoplasmic reticulum and the lysosomes in NPC. Here are controls, here NPC. When you give NALL, you increase the contacts, you show these lipid droplets forming again, and again you can measure that, showing here are controls, no change with NALL, of course. Here you see the NPC cells and an increase in these communications, these contact points between the ER and the lysosomes. And the most recent data, which was published as a preprint a couple of days ago, has found that the N-acetyl-L-leucine activates what's called transcription factor EB. It moves it into the nucleus so that it can activate what's called the clear system and increase production of lysosomes and lysosomal proteins, particularly LAMP1. It also restores autophagy, which is the normal pathway for recycling of organelles in the cell. And this effect occurs at concentrations consistent with what's seen in therapy. It's clear that it's actually the acetyl-leucine which is doing this. The L-leucine itself doesn't. So it's showing that this drug is having a very important effect. And there's more work ongoing in this field at the moment. I'm not going to go through this in detail, but basically to show the N-acetyl-leucine gets into the cell, it inhibits mTOR. That inhibition of this mammalian target of rapamycin, as it's known, normally inhibits the translocation of TFEB into the nucleus. If you inhibit the inhibitor, you get translocation of the nucleus. When the L-leucine is released from the NALL, it then activates the mTOR and shuts it off. So you're getting bursts of this activity. And I think that's very important because if you had continuous stimulation of this pathway, it probably wouldn't work. So I think that's important to the mechanism. I'm not going to go through these clinical studies in great detail because you're going to hear about this from Taylor Fields later in the meeting. Just to say we had a randomized double-blind controlled crossover trial with two 12-week periods. So all patients received drug. They all had the opportunity to go into an extension phase. Subsequently, we used a large number of endpoints. And essentially what we saw is for all of the endpoints, there was improvement during the drug phase with reversion during the placebo phase. And some patients had a challenge, washout, re-challenge, and with each challenge, they saw benefit. Again, I'm not going through this in great detail because Taylor will show this to you later. The extension phase, we now have data actually out to 2 years, which will be released in Europe shortly, but showing the 18-month data. Here is a control cohort. This is actually the one used for the arimoclomol studies. The dotted line indicates no change. A value below that shows improvement. So patients showed improvement and they have maintained this to 18 months. And I can tell you it's now been maintained to 24 months. Now, the slope of this line depends on the cohort. So some people have said, well, that cohort was not an exact match for our study, which is true. But every cohort you look at shows a positive slope over this period of time. So there may be some difference in the magnitude of change, but the actuality of benefit, I think, is very clear. And again, you see the improvement of what's called the SARA score here, again showing maintenance of benefit out through 18, and now we know 24 months. So this drug was approved 4 days after arimoclomol, treatment of neurological manifestations of NPC in adults and pediatric patients weighing more than 15 kilos. So where are we in 2025 after all of that? Well, we have improved diagnosis. At least in the United States, now it's fairly easy to get whole exome and genome sequencing. Now, technically, this is not hard to do. What's hard is to get people to pay for it, but the cost is coming down and it's becoming more and more efficient. Even so, there are so many mutations in the NPC genes, particularly NPC1, that you really need biochemical backup. We now have that easily accessible through oxysterols and for newborns through bile acids. So this is a huge improvement. We have approved therapeutic options in Europe in the form of miglustat, in the United States, arimoclomol plus miglustat. We have L-acetyl-leucine. Cyclodextrin is under study, but it has not yet been approved. As I mentioned, the current experimental therapies include intrathecal cyclodextrin in the form of adrobetadex, as well as intrathecal plus IV, intravenous trapsol, which you'll hear about in this meeting, and you'll also learn about oral nizobaglustat, which is another inhibitor of glucosylceramide synthase. It's actually a dual inhibitor, which will shortly begin a study in NPC. We now have multiple clinical outcome measures. We still have some problems with the regulators, but they're generally accepted in the form of the NPC Clinical Severity Scale. The SARA scale has proven useful in the levoacetylleucine studies. We have many different biomarkers, things that you can measure which correlate with the presence of disease. But what we really need is something we can measure that correlates with the outcome, a so-called surrogate outcome measure, because if we had that, we could use that as the outcome for clinical trials, and that would simplify everyone's life. Newborn screening is technically feasible now with bile acids, But whether that should be the first step or sequencing, the order in which we could do that, if we're able to do it, is still under debate. But I think this is likely coming in the future. Where do we go from here? Well, one of the issues is how do we best optimize individual therapy? We don't know that. We don't have head-to-head trials of the different compounds. And I think this is going to be like treating many other complex disorders, such as epilepsy, where it really comes down to physicians tailoring the therapies to individuals. The better biomarkers and the better outcome measures we have, the more effectively we'll be able to do that. Again, we need surrogate outcome measures to be able to get accelerated approval and move these therapies through. I've mentioned that the accuracy is increasing and the cost is decreasing for whole genome sequencing. This, in theory, could allow carrier identification so you could primarily prevent this disease, something like what was done with enzyme screening for Tay-Sachs disease beginning 35 years ago, very effectively. It also means that we have a much greater chance of making an early diagnosis and intervening early than we did when I got involved in this field 35 years ago. Gene therapies are under active investigation. Gene therapy means many things. It can mean gene transfer. It can mean RNA therapies. It can mean gene repair using CRISPR. And I think you're going to learn something about that during the meeting as well. So I know that was a lot of information. I always begin my acknowledgements the way I began the talk by thanking NPC patients and families and caregivers who have allowed me into their community and taught me so much over the course really of my whole professional career. I'm very grateful for that, and I hope I've been able to contribute a little in response. I want to thank these investigators who are listed. And for those of you who like to read a lot, I have a long list of references that I'm happy to share. And I don't know if we have time for questions, but I'd be very happy to take any if you have them.
Thank you so much, Marc, for that update. That was fantastic. And I'm quite sure there will be questions. We'll have the roaming mic. I guess I will have a quick question while people muster up some courage. Let me grab my glasses for this.
Well, I want everyone to remember there are no foolish questions, although I may give foolish answers. So please ask whatever you want.
So my question is relating to, I'm an exercise physiologist. So for every problem I see exercise as a solution. And I grabbed hold of that inflammatory response and the use of lactic acid as a delivery, sort of that in and out process. Would something like increasing the flow of lactic acid therefore increase the mechanism? Like through, say, going into high intensity exercise where possible or something along those lines for deliveries?
Yeah, that is a great question. I think the answer is we don't know. I have to say that I actually strongly in your court, I am very strongly in favor of exercise and movement for everyone. And I think it's actually more important for people with, almost more important for people with neurologic disabilities than for otherwise healthy people. But it's a very interesting thought because in theory, based on what we understand, if you increase lactic acid production, you may actually enhance the uptake of this drug and increase its effectiveness. So I agree. Theoretically, that's true. We don't have any data to substantiate that.
Any questions? Yes.
I do see one here.
Questions? Yeah.
Yes. I see one that says, are there any dietary changes? Let me bring that up again. That would assist with the trafficking of cholesterol. We actually studied this at NIH way back in the 90s. And the pool of cholesterol which is involved in this disease is really not directly accessible to diet. That being said, I do think that following a healthy diet is important for everybody. And I think it's important to think, just as you want to optimize your exercise and your movement, I think you want to optimize your diet and reduce excessive animal fats in particular, because we know they cause problems with inflammation. So although we have not been ever able to show in the mice or in humans that a low cholesterol diet influences the biochemistry directly, I think if we think about the whole person and your health, it makes sense to follow a healthy diet with emphasis on fruits and vegetables and grains, minimize animal fats, minimize red meat to ensure you get adequate protein, but to minimize the inflammatory response and the negative consequences of that. It's a great question.
We do have a question on the floor. If we could get a microphone up to Amy. While we're waiting for that to happen, another question we talked about, you said this was in pediatric and adult populations. Is there a cutoff in terms of the progressive point of the disease? So were there people obviously that they wouldn't receive any treatments, or it would be seen as no benefit, or is there a potential for benefit for all people regardless of their point of progression?
Yeah, I think that's a great question, and that's partly a philosophical question, it's partly a medical question. I think there is a point in this disease where there is sufficient burden of disease. In other words, there have been enough neurons lost and enough neurons malfunctioning that it's unlikely that any therapy or combination of therapies is likely to substantially alter the course of the disease. That being said, speaking as a clinician, I would always have that conversation with families and patients and at least consider a trial of medication, because we don't know all about this or any other disease. And I think where we have medications that show a rapid response like N-acetyl-L-leucine, then a 6-month trial is probably going to tell if it helps. If you're talking about arimoclomol or miglustat, it's probably going to take at least a year to know if it's made any difference. So yes, there probably is a point beyond which you're unlikely to see a lot of benefit. And certainly we tend to exclude those patients from clinical trials. We tend to exclude people at both ends, those who have no symptoms because we have nothing to measure, those who are very impaired and would be unable to participate in the study, as well as not likely to be able to benefit. But in terms of clinical management, I think that really comes down to a conversation between the caregivers and the family to decide what's going to be best for that patient. I don't think you can make a blanket rule.
Thank you. Amy.
Hello, Dr. Patterson. It's Amy Leddick here. My husband Ben and I in the audience, we have a 16-year-old daughter with Niemann-Pick. I have 2 questions if I could quickly ask. One is to do with miglustat. We've been told by someone once that it is okay to skip doses with miglustat, particularly when she has some events that she likes to participate in. And because the gastrointestinal effects can be so unpredictable at times, we find, particularly with her, so that she can fully participate in her example is in theatre productions and not be impacted by the risk of having a sudden attack of diarrhea. What's your thoughts on skipping like a day or 2 of dose, just so that we can have that freedom of not having that fear of something happening?
I think that is a very sensible approach. Nobody has any data to say that if you skip a day here or there or a couple of days, that it really makes any difference to the outcome. And I think this comes back to you obviously have had a great discussion with a very sensible clinician, because you have to step back and look at the whole person. And if she enjoys theatre, then I think that's a very reasonable thing to do. And I think it's very unlikely that that is having any untoward effect. So I would certainly endorse that approach.
Okay, thank you so much. And if very quickly, now that our daughter has turned 16, she's now become eligible to participate in the IB 1001 trial, which we're looking at. We have only heard from, I guess, a few families about what they've experienced and what benefits has observed. It's been really mixed. Some can't really see what the direct, I guess, benefits. Some have been quite obvious. In your experience, what typically are the functional, I guess, improvements that you have observed in people in that trial?
Yeah, well, I think you raise a really important point, and that is everybody's different. So when we look at the results of all of these trials, we're looking at aggregate results. And so the aggregate result is that overall, people show improvement. The outcome measures that were used in the short term were based on cerebellar function, so things like ability to walk, talk, coordinate. The longer term data was based on the NPC Clinical Severity Scale, which is broader based. But everybody is different. And I will tell you, we've encountered patients who actually haven't seen any benefit for up to 6 months. There are others who see benefits within weeks. And I think this just emphasizes the diversity of this disease and its manifestations. So I don't think we can predict for any individual how well they'll respond. The drug does seem to be very well tolerated as far as we can tell. As I mentioned, the racemic form's been around for 68 years now, and there have been millions of exposures. So we're pretty confident there's no serious adverse event. I think the other thing you've got to think of is the context. Are people taking other medications? What manifestations of disease they have? Because all of these things are likely to impact the overall picture. So I think that's a fair point. But I wonder if these are patients in Australia who, I don't know that anyone in Australia has been on the N-acetyl-L-leucine. If you're talking about the N-acetyl-D-L-leucine, that's much, much less effective. So I'm not quite sure about that, but that would be something else to bear in mind.
We do have a question online. Why does the spleen become so enlarged, and does the therapies out there do anything to help with stabilizing the spleen?
Yeah, that's a great question. Initially, a large number of children will have enlargement of the liver and the spleen. As long as children don't have very severe disease that leads to liver failure, often the size of the liver will reduce, although there is evidence that over time you can gradually get fibrosis and very rarely even cirrhosis in the liver. The spleen is likewise enlarged because both of them are full of these foam cells. And these are macrophages which are full of lipids, including cholesterol, and it's basically a major storage site. The enlargement of the spleen means that the platelets in the blood can be trapped, so children tend to have a low platelet count. They also tend to have platelets which are less sticky, so there is a tendency to bleed and bruise more easily. Some children have nosebleeds, for example. People are often worried about the spleen rupturing. In 35 years, I've never encountered such a case, and I've scoured the literature and never found that it happens. The spleen, if you feel it, is actually rock hard. It's not like the spleen in infectious mononucleosis, which is very soft and can literally fall apart. So the spleen can cause problems in terms of platelets. If it's very large, it can be uncomfortable, but in general, it doesn't cause a lot of trouble. The current therapies really haven't been focused on looking at the spleen. It's possible, for example, if you gave intravenous cyclodextrin, that might help clear out the storage there and reduce the size. Otherwise, we just haven't looked at it, so we don't know with the other therapies. What we do know is the size of the spleen can go up and down based on intercurrent infection. So if you're sick and your immune system is activated, the spleen can transiently enlarge a bit further and then get smaller. A lot of children also seem to grow into their spleen as they get older, so it becomes less of an issue. So again, a great question, and I hope it wasn't too dumb an answer.
We have another question on the floor, so if we get the microphone up there, and I'll just throw in another random one. You spoke about that diagnosis odyssey in terms of it's taking over 5 years to diagnose. What is the time frame currently in the US from that process? How does that sit? Are you still in contact with that? We have a goal of trying to get it, obviously here Marc would like to get it under sort of 12 months or under. Is that
absolutely? Yeah, I don't think I have an absolute number, but I would say that I think there's much greater. I think there are a couple of factors. One is the availability of the tests. The second is people thinking to use them. And they're not exactly the same thing, but I think there's much more awareness of NPC than there was in the past. With genetic panels, for example, it's now included in genetic panels for jaundice in newborn. It's being included in panels for developmental delay and ataxia, as well as seizures. So I think that means it's an engineering approach. So I think the diagnostic delay is better. I don't have a hard number, and my guess is we're probably a couple of years on average, although there are still outliers. It's definitely getting better, but we have a way to go. I'll tell you, I honestly believe that as the cost of whole genome sequencing comes down and the accuracy increases, I think in developed countries, maybe within a decade, we'll all know our whole genome. We might not want to know, but I think we will all know. I think it will end the diagnostic odyssey. It'll increase the ranks of the worried well, but that's a separate issue.
All righty, so we'll grab that last question now from Ben on the floor.
Yeah, thank you. Hi, Mark. Ben Leddix, my name. The question that I have ties into the second last question. And so our daughter, when she was born, she had an extremely large spleen and a really diseased liver. We did meet you once at the Royal Brisbane through Dr. Jim McGill. Isabel was quite well at that stage. But since then, she'd gone on to have a liver transplant. And that liver transplant happened at Lady Salento in Brisbane 8 years ago. She's doing extremely well on that end, and the spleen sort of settled down, and there's no further disease in the liver whatsoever. I guess it is such a complex disease. There was a lot of reservations around putting Isabel forward for a liver transplant, but I'd just like to some insight into what you've seen around the world with some of the different patients, and if there've been many liver transplants and how successful they have become.
And also,
Yeah,
why
that's
is it that a new liver doesn't then develop Niemann-Pick? Like, why does it? That was always confusing to me.
That's two terrific questions. And the basic answer to the second part is that NPC is what's called a cell autonomous disease. And for example, some investigators in California some years ago made what are called mosaic mice, where in the cerebellum, there were cells, one Purkinje cell would have an NPC mutation, the one beside it would be a wild type cell. There was no cross transfer, so the wild type cell couldn't correct the NPC cell. The NPC cell didn't affect the wild type cell, or the normal cell, if you will. And that's one of the challenges. So it's why we can't give an infusion of the protein, for example. It just doesn't work. Even if you put the cells together, that doesn't happen. So my take is this. The first liver transplant for NPC was done by Tom Starzl, a very famous transplanter in Pittsburgh more than 40 years ago, for a teenager who had severe liver disease, and it was very effective in treating the liver disease. It didn't affect the neurologic course of NPC because it doesn't produce a protein which can get out of the liver and into the brain. It would be terrific if it did, but it doesn't work that way in this disease. My personal feeling is that particularly at this time, if a child has severe liver disease and needs a transplant and they can get one, they should have it, because we now have so many more potential therapies that if you can rescue the liver, you've got the opportunity to intervene and try to deal with the neurological disease. Does that make sense? If not, I'll try to explain that.
Thank you, Mark. That does. Yeah. Thanks very much.
You bet. Great question. Thank you.
Thank you, everyone, for your questions. And thank you, Mark, so much for your time. It's very much appreciated.